Thank you, Kudlu sir, for the introduction. So I'll be speaking about Colamer usage in low to moderate myopia. So when we started doing our postgraduate days, we were all taught that ICL means it's restricted for the patients who are having very high refractive error. With the day progressed, we started doing it for -6 to -10. But now this is a new normal. Doing ICL, especially the Collamar ICL in low to moderate myopias. I'm just a high volume ICL surgeon. Uh, no financial disclosure. As soon as I say that ICL is for low to moderate myopia, there are so many questions among the refractive surgeons itself and from the other ophthalmic fraternity. Is it safe, reliable? What's so about cataract? What happens if IOP fluctuates? What is the explant rate? Who and all are doing it? What about endothelial loss? Because they are bothered about the cataractogenesis, glaucoma happening in a young patient. What sort of endothelial loss happens? And there are not so much studies published yet. In my experience, I think last 4 5 years I've done a good number of ICLs, and to be frank enough, I have not explanted any ICL out of the patient's eyes, and nor any patient developed glaucoma. Because of my high volume, I always considered a Columnar as first among equals, along with corneal-based refractive surgery. I offer ICL as a primary procedure whenever the patient's pupil size is bigger than 4.8. 4.85 because EVO plus lenses, the optic zone has been enlarged now. So this becomes a primary option. Physiological thin corneas between 480 to 440, they are not suitable for PRK or PRK plus. They are the ideal candidates. Patient asking for reversible procedure, and there are some patients in my huge volume asking for the same procedure just because they have their happy friends and families. Early keratoconus, non-progressive keratoconus, stable keratoconus patients, irrespective of their refractive error, I offer them. Patients suffering from moderate to severe dries, especially post-corona, digital abuse, yes, ICL is the option. And any evidence of keratoconus in their family, worried about ectasias, yes, ICL is my offer. I always advise them that ICL also a good option because contrast is never last. Professions requiring very good contrast, ICL remains the first option. It is devoid of all the complications which can happen with corneal-based refractive procedures. And to do this phakic IOL, Colamer is the only best material if at all, if you're choosing for low to moderate myopia. And the criteria we know. And why this Colamer? Because this is one unique material, highly biocompatible material which can be used within the body. As soon as we say Colamer, it is biocompatible nature. It's a copolymer. It's hydrophilic in nature, almost more than 35% of water content. Because of it, it is very flexible. It is gentle, and the light transmission is almost more than 99%. See, the refractive index is around 1.4%. Rest of the materials, the refractive index is higher, almost goes more than 1.5. This is 1.45, nearer to the crystalline lens. What happens? The normal human eye secretes a material called as fibronectin. This fibronectin is attracted by the Colamer. This coats the Colamer. So the anterior chamber doesn't detect this as a foreign body. That's why we absolutely get a quite eye post surgery. Even a patient who might have suffered from idiopathic anterior-uveitis or traumatic uveitis, Colamer can be used. And one more thing we need to understand: 25 years down the line, ICL patients were explanting once they have become aged. We can see no deposits in the column. It looks so fresh. This happens because the negatively charged column repels all the negatively charged particles in the anterior chamber, unlike the other materials where you get the deposits of calcium all over the materials. The quality of vision, as I mentioned, is very very good because like 99% light transmission is there, and since the refractive index is nearer to the crystalline lens, internal aberrations are very much minimalized, and we are making incision of 2.8 to 3 maximum, so the product shape is maintained, the aberrations are not induced, contrast is never altered with this procedure. Long-term safety, even before the advent of central flow, the incidence of butterfly cataract was less than 1.3%, but with the advent of central flow technology, even this butterfly cataract chances are very much minimalized. Surgical time hardly takes 60 to 90 minutes. It's a peripheral incision, so endothelial cell loss is very very negligible. And any topical phacosurgeon can perform this procedure. If you look into the recovery time, microkeratomes, yes, we you do have all the symptoms of pain irritation for a day or so. With surface ablation goes until 3 to 4 days. Even with femtone smile, it ranges up to 8 hours. But ICL patients, the recovery is very very fast. Since they enjoy very good snellen vision, contrast is not altered. Patients remain happy. Even it's not extra added investment for the institutions. Also, any phaco surgeon can do it. If at all, if the complications they are very minimal, if it happens, it's a reversible procedures, and the results are not dependent on the temperature and humidity of the room like eczema. Because of all these properties, Qualamar gives me confidence to go ahead and do in low to moderate myopias, and because of it, so many ICL implantations have happened. This is my small experience, minimum of minus 1.5. I've operated, and all the patients had aced up more than 3. I have follow up of 2 years. All the patients do maintain very good vision, 6/9 or better, and the spherical equivalent is around plus or minus zero point 0.5. None of the patients are on anti-glaucoma medications, and they remain happy. Thank you.
Thank you very much. Thanks a lot.